Sir, nakamute ka po.
High pitch pa naman ako. Mute pala. Anyway, thank you very much for that. So again, good evening to everyone. This is now the time for us to continue learning as it speaks. And since we have already talked some concerns and open our minds on learning, we have already discussed, let's have first a recap of what we have discussed last time. We have already discussed some of the concepts related to pharmacology. We have discussed about pharmacokinetics, pharmacodynamics, pharmacogenomics, and pharmacotherapeutics. We have simply defined these terms related to pharmacology by having its alignment on M's. We have mentioned about pharmacokinetics. In pharmacokinetics, this is related on movement. And if we talk about movement, there are stages that we consider for movement in pharmacokinetics. We have A. Can I hear you? What's A?
Absorption.
Absorption. Next, D.
Distribution.
Distribution. M.
Metabolism.
Very good. And letter E.
Elimination.
Okay, so elimination or excretion. So from the movement itself, it gives us the idea of how the drug enters the body from the time that it will be absorbed and up to the time that it will be distributed via plasma. And before it will be metabolized, it will consider the liver function, then elimination as with the function of the kidney. So mainly, this concept of absorption, distribution, metabolism, and elimination gives us the idea that the drug, 100% of the properties of the drug, all of us may have different response on drugs and medications because it may depend specifically on how our body respond to it. Why there are some instances that an individual completing the antibacterial for 7 days have not recovered or had not been treated. It's because it may depend on the body. If there is a pre-existing condition, if the person may have comorbidity, this may cause the possibility of inhibition of the ADME. The next term that we have considered in pharmacology is pharmacodynamics. In pharmacodynamics, we have considered how the body already respond from the expected effects of the drug. So that's why it's more on the biological and physiological change of the drug that is taking place within the body. And with that regard, we have discussed various terms that is related to pharmacodynamics. Those that are the expected effect of the drug refers to the side effect. The unexpected or the untoward effect of the drug refers to adverse effect. How about if the effect has been identified as a severe adverse effect and it is already life-threatening and dangerous? That is already referring to toxic effect. So we have also discussed what are drug tolerance, drug dependence, drug abuse, therapeutic, and desired effect. So these are the terms which will give us the idea if the body is not anymore responding appropriately to the drugs. Because somehow your body and mindset, you are already dependent on those drugs when it comes to management of disequilibrium or concerns with health conditions, altered health condition or dysfunction. So that's the basic difference of non-pharmacological and pharmacological management. The non-pharmacological management are those measures which is not supported by drugs or medication, deep breathing exercises, tepid sponge bath, the concept of conduction and convection. Those are the measures that will basically support on the prevention of alleviation of situation or health condition. Somehow, if these measures may not be effective or efficient, then the pharmacological management will be the one that will supplement, mimic, and supply the needed response supposedly by the natural response of the body. Class, remember, if we are in pain, our body, even without drugs, even without medication, can lower down its severity because we have the natural substances such as enkephalins. These are the substances by which the enkephalins may support to prevent the prostaglandin synthesis that may lead to fever. And as what I have mentioned and to you, cytokines, okay, yung cytokines that if there are situations of starting inflammation, the cytokines are naturally released by our body as an anti-inflammatory to prevent effects or complication of inflammation. Somehow, if the cytokines are not sufficient, then there must be something that will mimic the action of cytokines, which are the pain relievers. So those are the aspects by which concepts of pharmacology is very significant for us nurses. The pharmacogenomics will give us the idea on makeup genes. Because, for example, if it runs into your family that you have history or familial history of hypersensitivity reaction or allergic reaction, asthma. So these are sensitive health conditions that may merely affect management or pharmacological management to individuals because this may hinder the effect of the drug. Last but not the least is we have pharmacotherapeutics. If we say pharmacotherapeutics, this will give us the idea on how it will lead to its indicated system or organ that the drug is taking into effect. From the term itself, therapeutic, it's the desired effect. So those are the four concepts. Ayan, napuyok na. Puberty. Those are the four concepts. Babaan natin. Those are the four concepts that is important when it comes to pharmacology. So let's start on the detailed discussion about pharmacology. I will be showing to you a video presentation which was also posted in the MCUBLE for your reference. So let's start this video.
Hi, this tutorial is the first in the Pharmacokinetics series. So first of all, I should talk about what pharmacokinetics is. Within pharmacology, we often talk about two distinct, but unfortunately unintuitively named branches. These are pharmacokinetics and pharmacodynamics. Briefly, pharmacodynamics is the study of the effects of drugs on the body. That is, what does this drug do to the body? What receptors does it activate? And what other effects does it have? Alternatively, pharmacokinetics is the study of the effect the body has on drugs. In pharmacokinetics, we ask questions like, how does the drug get into the body and where does it go? What does the body do to the drug? And how does the body get rid of the drug? It is this branch of pharmacology that we will be looking at in this series. So let's begin with a pharmacokinetics acronym you'll find in every textbook of pharmacology. ADME. A-D-M-E. This stands for absorption, which is how the drug gets into the body. Distribution, which is where the drug goes to in the body. Metabolism, which is how the body chemically modifies the drug. And finally, excretion, which is how the body gets rid of the drug. These are 4 elements we need to consider when talking about the pharmacokinetics of a certain drug. The following tutorials will each talk about a certain aspect of pharmacokinetics. But for the remainder of this tutorial, we are going to discuss some of the more boring but incredibly important aspects of pharmacokinetics and pharmacology. So I'll begin by drawing a graph. And here on the y-axis, we have the concentration of drug within the body. And on the x-axis, we have time. So if we give a person a drug at time 0, then we will see the concentration of the drug go up, and then it will fall slowly as the drug is removed from the body. And that's what we see on this graph.
So as what you have seen in the presentation, the set example when it comes to pharmacokinetics is when the time that you give the drug, it means that with the knowledge that you have, that try to consider that the drug outside your body, the properties of the drug and the chemical components of those drugs is 100%. Okay, it's 100%. So that's why on the time 0, from the time that I take the drug, then it will increase its concentration. Meaning, as the body absorbs the drug, it is still 100%. And if you imagine why the graph, when it reaches the highest concentration, goes down. Why? Because these are the situations that I even told you that not all the 100% is needed by your body. Why? Because you have also the natural response of your body. You have the reserved substances of your body that is still working for that situation. Which a typical example is pain. The 100% pain reliever of the drug, for example, mefenamic acid. You're not taking the drug, you're holding the capsule, it's 100% with its chemical properties of it. Once you take the drug, that's the time that the process of absorption takes place, wherein still the drug is on 100%. But why is it he mentioned here that the graph goes down? As it considers from time 0 until it goes with the running time. Habang lumilipas yung oras, it may cause the possibility that may decrease concentration of the drug. Why? Because at the time that prior to the distribution, it will still first be undergoing metabolism by the liver. Diba, we have mentioned that not all the components and properties of the drug are needed by the body. So meaning, the liver is responsible, okay, the liver is responsible for detoxification. Why need for detoxification? Because the liver will identify only the drug concentration that is only needed by your body. If the liver will not act on it, it may cause or it will not cause its metabolism by the liver. There is a possibility that the level of concentration of the drug that will be distributed sa plasma will be higher, and that is toxic effect. And any toxic effect, any higher level of concentration is already toxic effect, meaning the toxic effect itself may significantly alter cellular function. So that's why when you consider the concentration, it goes down because the other portion of the drug will be now distributed in the body. But what happens to the other components of the drug which were already detoxified by the liver? Will it still stay in the body? The answer is no, because that's the function of the liver to meet only the specific requirements that is needed by your body. The excess of it, from the term excess, if it stays, it will lead to toxic effect. So that's why the excess properties and chemical components of the drug will undergo excretion and excreted. So meaning, from the concentration of the drug until the time that the concentration goes down because it is metabolized, because it only identifies the need concentration of the body. So the other components of the drug will be removed by the body and excreted accordingly. Any questions so far? So let's continue with the video presentation.
Looking at this graph, we can see that in this section, the drug enters the body faster than it is being removed from it. Therefore, the concentration of the drug in the body increases. Then, after the peak of this graph, the drug is being removed from the body faster than it is entering. So the concentration of the drug in the body starts decreasing.
So if you will notice, more drug in than out, more drug out. So it means that at this point, more drug, higher concentration of the drug enters the body. Then from this peak goes down because more drug out of the body because of the excess chemical components brought about by the metabolism. And once the excess components of the drug that has been metabolized, then that undergoes specific next portion for the pharmacodynamics to be distributed, and the other portion proceeds to excretion.
So the concentration of the drug in the body starts decreasing. This point at the top of the graph is important because it is the highest concentration of drug in the body. Therefore, we call this the maximum concentration, or Cmax.
Okay, class, that's why if you will notice why drugs are given and prescribed by the doctor with specific time. Why? It's because, for example, the drug is given every 8 hours. The first dose is given at 12 noon. So if it is every 8 hours, what will be the second dose? So it will be 1, 2, 3, 4, 5, 6, 7, and 8. So meaning, if it is given 12 noon, the next dose is 8 o'clock. That period of 8 hours, the drug is working in the body. As the time goes, it may reach the point that the drug is being processed in our body and somehow may meet the what we call the highest concentration level. And that is what we call the maximum concentration of the drug. So if, for example, between 12 o'clock up to 8 o'clock, let's have the half of the time. From the 8 hours, the first 4 hours goes with what time? 12 noon, then goes 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock. So meaning, at around 4 o'clock, the drug already reaches its maximum concentration. And after 4 o'clock, it will start now to what? It will start now to decrease the concentration because this is now the period of the what we call metabolism and excretion. Class, very important to give the drug on time. So can you imagine that if, for example, the first dose is 12 noon and supposedly you give the drug at 8 o'clock, the half-life of the drug, which reached the maximum concentration level, was 4 o'clock. And it's decreasing already the percentage of the drug. So meaning, you need again to support continuity of the drug. Meaning, you must give the drug at 8 o'clock. So there must be continuity. Sir, is there a problem, for example, that I have missed to give the drug at 8 o'clock and gave it at 9 o'clock? So can you imagine that from this time of 12 noon, 4 o'clock, and this is about 8 o'clock. So meaning the drug, the concentration of the drug is at its lowest level and may need to continue again with the next dose of drug so that there will be again continuity of the drug to follow this graph. For example, at 8 o'clock, it will start again its concentration, until again it will follow this graph of decreasing the concentration through the process of ADME. So that's why it is very important to give the drug on time because of the situation that the half time of the drug may reach the maximum concentration level, and once it reached the maximum concentration level, it will start to decrease and will process metabolism and excretion. Are there any question, class? Any question?
None po.
None. Okay, so one thing that you must remember, give the drug on its appropriate time. That's why the doctor already identified the time. If, for example, the drug is given 3 times a day, 8 o'clock, 1 o'clock, 6 o'clock. So from 8 o'clock to 1 o'clock, 9, 10, 11, 12, and 1. So what would be the half? So 5 hours difference. What could be the half-life noon? The half-life could be 9, 10, around 11. So at around 11 o'clock, you're aware that the concentration of the drug already reaches its maximum concentration. And it starts now to what? It starts now to lower down its concentration because it's already reaching the point of metabolism and excretion. So at the time of 1 o'clock, it means that the concentration of the drug is at its lowest level. So you need again to support the next dose immediately so that to support again continuity of the continuous concentration of the drug. So let us continue with the video.
This is important because knowing the maximum concentration can help predict the therapeutic benefit and also the likelihood of side effects. The time at which the maximum concentration occurs is called Tmax. Now, a slightly more confusing concept is the half-life of a drug.
Okay, so we have mentioned about the maximum concentration. We have mentioned also the maximum time. The example that I gave you is related to, for example, the drug will be given every 8 hours. So it started the dose of 12 noon and will end yung 8 hours period at 8 o'clock. We are aware that the concentration of the drug will reach its maximum concentration at 4 o'clock. And that's the time that it reaches the what we call the half-life of the drug. Because seemingly, once it reaches the maximum concentration of the drug, 50% of the drug are already possibly distributed and the other 50% will possibly be metabolized and excreted by the body. So that's why it leads to the lowering of the concentration of the drug. The 4 o'clock that I have mentioned is considered as the maximum time, and that is also the maximum concentration, which considers also the half-life of drug. So let us continue.
The half-life is, by definition, the time it takes to remove half of the current concentration of drug from the body.
Okay, the half-life that we are mentioning is that of, this is the time, this is the period, okay? Maximum concentration of the drug and the maximum time. This is the peak that the concentration of the drug that enters the body is at its peak. And at around 4 o'clock, it leads to the what we call half-life. Then the other 50% of the drug starts to lower the concentration and be removed by the body. So that is the what we call half-life.
So let's consider the half-life on this graph. If we begin at Tmax, we want to see how much time it takes for the concentration of the drug to decrease from Cmax to half of Cmax. So here is the half Cmax line here. And therefore, the half-life, which is often denoted T half, is the time between Tmax and where I've drawn T half here. So just to summarize, the time it has taken for the drug to drop from its maximum level to half of its maximum level is the half-life. On this graph, this is the time.
So again, as defined by the facilitator in the video, the half of the maximum time and the half of the concentration of the drug, which is this one, is considered as half-life. Again, the half time and the half of the maximum concentration refers to the half-life of the drug, and the half-life itself starts to decrease because of the process of metabolism and excretion.
Between Tmax and where I've drawn T half. There's a lot more to talk about with half-lives. Including rate laws and orders of reactions. But that is beyond the scope of this video, so we'll talk about that in a later tutorial. The last thing to look at is the area under the curve, and this I have illustrated by shading in the space under the graph. This represents the total exposure to a drug that the body receives. This is a function of how high the concentration of the drug gets, as well as how quickly it's excreted. And that's an introduction to the basics of pharmacokinetics. In the next video, we'll look at routes of drug administration and how different routes can affect Cmax and Tmax.
So eventually, with this idea and concept that I have mentioned, the total exposure of the drug. So this follows through that I even introduced to you the routes of administration. The matter that if the drug directly administered and reaches the blood and the plasma, the greater the chance that it will reach up agad yung concentration of the time, and it will reach also faster for the half-life of drug. The longer, what are those routes of administration that may have longer concentration of drug and time? Topical. Why topical? Topical usually are drugs that are administered through skin, ointments. If it will be administered on the skin, can you imagine the different layers before it will reach the blood and the plasma? From the dermis, epidermis, subcutaneous tissues, from the fats, reaches the blood vessel, layers of the blood vessel, the blood, then plasma. So that's why longer period of expected effect of it. Another, oral. The oral medications or oral route may have longer time of reaching the concentration and longer time that it will decrease its concentration and reach the half-life. Why? Because the drug starts to process and synthesize in the stomach, followed through with the intestine, and before it will be distributed, here comes the liver that will still detoxify. So try to imagine the time frame that is being compared to intravenous drug compared to oral drugs. Put this in your mind. Almost all oral drugs or drugs through oral route are detoxified by the liver. Oral. Very rare, sometimes not anymore, if the drug already reaches the plasma through intravenous, intraosseous. Kaya that's why most of the oral drugs that passes through the GI will be detoxified by the liver. Unlike if it is intravenous, it may not anymore have the process of detoxification which is longer than oral medication. Okay? So this is the video. So now, as we go on with the pharmacokinetics, we have mentioned that this is related to movement and it relates to the drug across body membranes to reach its target organ. Because if its therapeutic effect, we are talking about its therapeutic effect, we are considering a certain drug that will also target health conditions that are identified with the specific system of the body. Which one of the example that I gave to you is that of salbutamol, which had been identified for respiratory system. And since it has been identified in the respiratory system, then very obviously that the drug, its target organ and target system is a respiratory organ, either the lungs or any airway passages related to the air ventilation or the process of gas exchange. So these are the 4 stages of drug movement: absorption, distribution, metabolism, and elimination. Elimination or excretion could be the same. Next slide. This is now how you will understand the differences or the chances of absorption that will vary based from routes of administration. So let's start the video presentation. Absorption.
Hi, this tutorial is the second in the Pharmacokinetics series. And in this video, we're going to have a look at absorption, or more specifically, routes of drug administration. If you haven't seen the previous tutorial, I highly recommend watching it before continuing with this video, as we will use terminology which was introduced and defined in that tutorial. So I'm going to begin by drawing a very simplified body plan. And this body plan follows the flow of blood from the digestive system to the arterial circulation. So let's see how this happens. So blood flows from the gut to the liver via the hepatic portal system. Blood then flows from the liver back through the venous circulation and into the right side of the heart. The blood then flows through the pulmonary arteries to the lungs. Then from the lungs back to the left side of the heart, then out into the aorta and into the arterial circulation. What we are going to do is place drugs into different parts of this system and measure their concentration in the arterial circulation over a period of time.
Okay, the one that you're seeing on the or witnessing in this video is that of it simply identifies how circulation takes place in different organs. So we have the GUT, the genitourinary. We have the gastric, specifically. We have the liver. We have the vein that specifically consider that carries the non-oxygenated blood. And once the non-oxygenated blood enters the heart, it will be oxygenated by the lungs. And once it will be oxygenated by the lungs, it goes back again to the left side of the heart and proceed to the aorta via the artery and become oxygenated. So in this situation, it will showcase if the drug will be given via the lungs, it's via inhalation, nebulization. How about if the drug will be given directly to the vein? What will happen? So let us witness with the video.
So I'll draw a set of axes. And on the y-axis, we have blood concentration of drug. And on the x-axis, we have time. We'll begin with the most common route of drug administration, which is orally. These drugs move through the digestive system and get absorbed by the gut. Then they move through this whole system. That is, the liver, the venous circulation, the heart, the lungs, back to the heart, and then to the arterial circulation. This takes quite some time, so what we see is a slow rise in the blood concentration and then a slow fall. Note that the Cmax is quite low and the Tmax is quite large.
So if you will notice, as what I have mentioned in the first video of pharmacokinetics, the first example in the video is referring to oral drugs. So can you imagine before the drug reaches the oxygenated blood, the plasma of the oxygenated blood, it will pass through, di ba? For example, the drug taken orally, go to the gastric, okay, to the gastric. Then, as what I've told you, any oral drugs will be metabolized by the liver. After it will be metabolized by the liver, the chemical properties of the drug will be distributed, okay, will be distributed by a vein. And through the vein, we have the blood, the plasma, that is non-oxygenated. It enters the heart, oxygenated by the lungs, goes to the left side of the heart, and circulate through the artery as oxygenated blood with the drug concentration that is carried by the plasma. So can you imagine the period, okay, the period of time that passes through that oral drugs takes place. So that's why the merong longer period of time of effect of drug is most oral drugs. So from this graph, it reaches to the point that it maximizes the axis. It maximizes the axis. So this leads to the peak concentration. Then dun pa lang specifically nag-reach into the lowering of the concentration. So longer. It maximized the whole time that the drug had been administered. So this is related to oral drugs. So let us continue.
We'll now contrast that with intravenous administration. Assume that we give the same dose of the drug intravenously. And for those who have read ahead, this drug does not undergo first-pass metabolism.
Okay. Class, the term that are being used when the oral drugs are being metabolized by the liver is the first-pass effect. Again, I repeat, any oral drugs that passes through the metabolism of the liver is the process of first-pass effect. And first-pass effect only happens for oral drugs. Why? Diba? The oral drugs passes through the genito-urinary tract, genito-gastric, I mean. So from the stomach to the intestinal, then absorbed. Okay. Now GUT, liver. So first pass effect. Unlike if the drug is given intravenously. So it's within the vein. So it means it may not anymore go back to the liver and to the GUT for the process of the first pass effect. So as a concept, all oral drugs that passes through the GUT will undergo the process of first pass effect of the liver. Once it is given the vein, the shorter pace that the drug will have its effect. So let us continue.
In intravenous or IV administration, the drug doesn't have quite such a long journey to reach the arterial circulation, as it only has to go to the heart, the lungs, back to the heart, and then to the arteries. This results in a quicker rise of drug concentration, which might look something like this on the graph. Note that the Cmax is larger and the Tmax is smaller, even though the dose was the same. This is because IV is a more direct route of administration than orally.
So again, the term used by the facilitator is direct route because it reaches already the blood and directly with the plasma. So that's why the earlier time that it already reaches the maximum concentration of the drug. Plus, another concept is the drug reaches the maximum concentration if it already reaches the plasma. So that's why if you will notice, if the drug is given via the vein, the shorter period that reaches the maximum concentration because it is already directly access, it has a direct access to the plasma.
Now contrast this with inhalation of a drug. Let's again.
Okay, the next route that will be discussed, we have first the oral, second intravenous. Now, how about if the drug is being inhaled? Okay, being inhaled or by nebulization, by aerosol. So let's see the difference.
We can assume that we have given the same dose of the drug as the last two examples, but this time we are giving it as an inhaled form.
Inhalation.
Many anesthetics are actually given this way. The drug now only has to go to the heart and then straight on to the arterial circulation. This means we will see the concentration of the drug shoot up very quickly. So note the much larger Cmax and the even smaller Tmax via this route of administration.
Okay. If you will notice, if it is via inhalation, as mentioned by the facilitator, it will only pass through the heart and reaches the artery. Number one, if it is oral, it passes through the liver, first pass effect, vein, heart, lungs, heart, before the artery. So can you imagine the stages of 1, 2, 3, 4, 5, and 6? So ibig sabihin, if you will understand yung first, the longer the time before it reaches the maximum concentration of the drug. So the intravenous may pass only the heart, the lungs, the heart, then the artery. So the shorter period that it will reach its maximum concentration. How about if the drug is given via inhalation? So it will just pass through the heart and the artery. So it means the shorter time that it will reach the maximum concentration level. But try to imagine, try to check that all of those drugs reaches the certain period of what? Certain period of the lowering of concentration. But the basic difference between the three, or with these three routes of administration, the shorter the period reaching the artery, the fast that it will reach the maximum concentration of the drug. So let us continue.
Also, remember that in all these three examples, the dose of the drug was identical, only the route of administration changed. So you can see how different routes may cause a radically different Cmax and Tmax. This is important when considering the applications for certain drugs. For instance, if you need pain relief quickly, then an IV analgesic will get into the system much quicker than an oral one. Conversely, a drug which has side effects at high concentrations may be toxic if given intravenously, but the same dose might be safe if given orally.
So did you hear the statement of the facilitator? Most of the drugs that will prevent toxic effect are more advised to be given orally kasi it will have the first pass effect sa liver. If the drug is eventually on a higher concentration or dose, the greater chances that it will lead to its toxic effect immediately because it will not pass through the first pass effect of the liver. So that's the main point, that most of the oral drugs are nephrotoxic and hepatotoxic because it passes through the first pass effect and the liver has a major function with it.
Now I have three more points I want to make. Firstly, note that the area under the curve is the same for all these routes of administration. This is because The amount of exposure to the drug, that is, the dose, is the same. Just some routes of administration spread the dose out over a greater length of time. Secondly, you might be wondering why the same drug is excreted at different rates, or more simply, why curve number 3 falls quicker than curve number 1. Without going into too much detail, I have chosen to show a drug that conforms to first-order kinetics. If you don't know what that means, it's okay. We'll cover all this in a later tutorial. But it basically means that the rate of excretion is proportional to the current concentration of the drug. If the concentration of the drug is high, then it will be excreted faster than if the concentration is low. Also, it's important to note that the half-life of the drug is the same regardless of the route of administration. This is because the half-life is a property of the drug, not the route. It will take the same amount of time for the drug to reach.
So remember, the half-life of the drug is referring to the drug itself but not by the route. So ibig sabihin, it means that even given these drugs, even given on different routes but of the same dose, the half-life will be the same, and it is not dependent on the route. All of the time of half-life will be the same for all. But immediately, the difference lang with the route is the time wherein it reaches the maximum concentration if it is given through the number 3, number 2, and number 1.
Half of the Cmax orally, as it will to reach half of the Cmax intravenously. This is because the Cmax is different for each route of administration, and the rate of excretion is proportional to the current concentration of the drug. In the next tutorial, we'll look at the metabolism of drugs. In particular, we'll look at the actions of cytochrome P450 in the liver. If you've enjoyed this tutorial,
Okay. Do you have any question with the previous video that we have played and demonstrated? Any question from the body?
Sir, paano pag mga antibiotic? E di
Yeah.
po kunyari, gumaling na yung patient. Gumaling siya for the next 2 days nung pag-take niya ng antibiotic. Di ba parang 1 week po yung tuloy-tuloy?
Yeah.
E di po yung 5 following days, iihilang niya po talaga yun.
Try to, kasi the point is, if you have asked about the antibiotic, kasi how can we say that the patient are already have already achieved treatment in just 2 days of the antibiotic? Usually, if you will notice, di ba, most of the oral antibiotics, these are on the span of 1 week. 1 week kasi mas matagal yung, mas longer yung time that it will inhibit the synthesis of the microorganisms. But if you will notice, but if the drug is given intravenously, usually it may not reach 7 days. So that's the difference. That's the difference. If the drug is given orally, the longer yung period of time that it acts on the body, because di ba as the video shows, it will pass through the GUT, the liver, the vein, the heart, the lungs, the heart again, then artery. So long pace yung effect of the drug. So that's why it gives 7 days. It is prescribed within the 7 days. Unlike for the intravenous, it may not need 7 days to administer the drug because intravenous, mas mabilis yung concentration level that will achieve the treatment of the patient. So that's why, what will be our basis that the patient already achieved treatment with the dose of the, for example, 2 days antibiotic? Example, the client has respiratory tract infection. Then after 2 days, the client will have again sputum test. If the client have the sputum test or culture and sensitivity test for 2 days and revealed the revealed the results that it's already what? It's already decreased yung quantity of the microorganism. It means that the antibiotic through intravenous given by 2 days are already what? Sufficient and support. But can you imagine in the hospital, di ba once the antibiotic had been discontinued, it is what? It is continued by the oral. Di ba pag sometimes if we discontinue the IV drugs, the doctor, okay, shift this to oral drugs. Stop the IV drugs because we need to support this with oral drugs na. So that to sustain the inhibition of microorganism. So remember class, that's why for oral drugs, it takes 7 days because it could be possible if your basis only that the patient had been treated for 2 days because he doesn't have any fever at all, the greater chances that few of the microorganisms had been inhibited with its growth. But the other bacteria present are starting to increase in number. So that's why this most of the antibiotics that are being given now by our doctors targets both gram-positive and gram-negative bacteria. The disadvantage if the doctor will only give gram-positive, will only target gram-positive, the bacteria that are gram-negative are the ones that are now increasing in number. So that's why it gives again the synthesis that leads to infection. So that's why most of the doctors are giving broad spectrum antibiotics that targets both gram-negative and gram-positive. So Mr. De Leon, with your question, how about if the treatment, or how about if the patient had been given intravenously for 2 days and you have mentioned that the patient had been treated, then antibiotic will be discontinued na. But it must be supported with diagnostic examination as a proof that the client had been treated with a type of infection. Did I answer it, Mr. De Leon?
Yes po, sir.
Thank you so much.
Thank
Any
you.
other question from the video presentation? So if you will notice, yes, please. Miss Abante? Okay, Miss Abante. Yes, Miss Abante?
Check lang po ng chat.
Pa-check po ng chat. Okay, so I'll just okay. So I have pala chat questions from the chat room. Okay. If di dadaan sa liver, paano po yung excess? That's the point. It's impossible if the most of the oral drugs automatically will pass the liver. All oral drugs. So safe, 'di ba? Safe tayo. So we could have that idea na okay, all oral drugs kasi pass through the GUT tapos will have first pass effect ng liver. So they detoxify. Now I think the one that you are thinking about is paano sir yung intravenous na hindi, it may not pass the liver and eventually proceed to the plasma. There are many ways for the body can eliminate the excess portion of the drug. Pwedeng through perspiration sa pawis. So pwedeng hindi siya dumaan sa liver but there's other way of eliminating the excess. So pwede siya sa through perspiration. Ano pa? Pwedeng the possibility kung excess yun, pwedeng through stool. So pwedeng mag-pass through stool. So another is pwedeng in excess, di ba pag toxic effect, pwedeng the person may vomit. So that point, that the toxic effect. So there are many other ways na even if, for example, intravenous, if it reaches the toxic effect, the liver will take part pero more na gumagawa ang liver sa first pass effect sa oral. So if it is in excess for intravenous and for other drugs, it may be removed. Pwede rin yan ma-remove via exhalation. So if it is in excess by inhalation, exhale yan ng lungs. That's another way of excretion. So as what I have mentioned, kung excess yon via intravenous sa drug, it will pass through It will pass through via perspiration or skin. Kaya if you will notice, Ganito po yon. If you will notice, may mga situations na given via intravenous tapos nagmamanifest yung odor sa pasyente because that is another way of excreting excess property of the drug. So yun yung other ways and the other means na if it is intravenous and other routes of administration, other exit in the body or means of exit sa body ang ginagawa ng body natin. Unlike for the oral drugs, usually via kidney. Kaya that's why most of the oral drugs are nephrotoxic and hepatotoxic. So did I answer it, Miss Abante?
Yes, ma'am. Thank you po.
Thank you. So again, another question. How about, sir, yung rectal? Yan. Yung rectal kasi, so example, suppository. Diba? So with the suppository, remember, the GUT already absorbed it because there's already the presence of the blood vessel doon. So ngayon, if it is already present in the blood vessel, so nagda-direct na siya sa plasma. So pag nag-direct na siya sa plasma, so eventually hindi na siya papasok, hindi na siya magpa-pass through the liver. Kasi nag-circulate na siya sa nag-circulate na siya via direct plasma. Unlike yung sa oral, pagpasok sa stomach, pasok sa intestine, tapos punta dun sa punta sa liver for first pass effect. Sir, yun nga po. Pumasok na siya sa intestine yun, 'di ba, sir? That's like for the oral, pumasok sa stomach, pumunta sa intestine, tsaka pa lang po papunta sa liver for detoxification. My question is, sir, pumasok na siya sa rectal as suppository directly to the plasma. So just the same as for the intravenous, dumiretso na siya sa plasma. Na-distribute na siya ngayon via the circulation na hindi na siya dumadaan via liver. So another means yan ng pwedeng paglabasan ng excess properties of the drug. So it may not be through the urine. Since it is directly to the intestine, it is via pwede stool, perspiration, and other means of excretion other than urine. Yun po. So I other question. How about paracetamol? The question related to paracetamol, you're correct. Most that it's every 4 hours, minsan every 6 hours. Pero remember, 'di ba? We have only range of temperature when you take paracetamol. 'Di ba? Although paracetamol every 4 hours if temperature higher than 37.6 and up. So that's the time that you will only, even though it's every 4 hours, pero PRN siya. So what do you mean by PRN? As necessary. There are some situations, sir, may nadidinig kami, paracetamol every 4 hours round the clock. So ibig sabihin, if it is round the clock, every 4 hours, the drug will be taken regardless of the temperature. So it may depend on the prescription of the doctor. So if it is every 4 hours for temperature higher than 37.6, that is on the case of if it is necessary. If the drug or paracetamol is given every 4 hours round the clock, class, di ba, remember, iisipin mo paracetamol, yan po yung that is the one that you have mentioned, the may toxic effect sa liver, sir, ha, tapos every 4 hours pa. So once it will reach, for example, na it's not treated with the oral paracetamol, then it's the time to give intravenous paracetamol para ma-prevent yung damage sa liver. So that's why if the temperature is not treated by oral, okay, there is a need not to run in the hospital and have the intravenous line for intravenous paracetamol. So that is the time that it will give us the idea when is the time na it will discontinue the drug or if it is still appropriate yung drug na given for every 4 hours or every 6 hours. So yun po. So every 4 hours, if it has a corresponding range of temperature, if it is round the clock, then we must be careful. We must do primarily na as much as possible ma-prevent yung every 4 hours you will take. Pero kasi, why it is prescribed every 4 hours? Because that is the time frame that every 4 hours safe for the liver to detoxify the drug. But if you will take paracetamol every 2 hours, every 1 hour, class, that expect the liver to have overfunctioning and may lead to possible damage. And possibly this may cause the chances that it may lead to liver problem if it will have the shorter period of time of having the paracetamol. So hoping did I answer those questions that I saw in the chat box? Any other question? So thank you for that. It explored it really explored very relevant questions that you have addressed. Thank you for those who participated. I hope out of the 44 students that I may have here, I may hear also questions in the chat box, or you may unmute to address your questions as well. Okay? Next po. So since we have discussed about absorption, all you have to do is remember absorption with AAS. AAS. The movement of drug, pag absorption level, if it is within the absorption level pa lang, that is with AAS. Meaning, what do you mean by AAS? From the administration site, across the tissues, systemic circulation. So these are the three concepts that absorption takes place. What do you mean by administration site? It could be rectal, it could be oral, it could be intravenous. That is referring to administration. So from the time that you administer the drug to any route of administration, you are already starting the first stage, which is absorption. Now, once the drug had been administered of any of these routes, then eventually it passes through the tissues. Okay? Depending on the route. Then afterwards, the target is to reach the systemic circulation. That's why if you will notice doon sa discussion natin ng pharmacokinetics, di ba it will end up into the artery, it will end up into the blood circulation. So you have noticed and observed that the shorter yung pace ng drug, the greater chances of short pace that it reach the maximum concentration level. So remember, if we say absorption, AAS, A, administration site, A, across tissues, S, systemic circulation. Site, across administration, across systemic. So ibig sabihin from the start that it has been given until it reach the blood. So there are situations that will affect the degree and rate of drug absorption. So it may depend. Example, administration route. As what I've told you, what are those routes that may reach immediate maximum concentration level and maximum time maximum time? It's through intravenous and through intraosseous. Why? Because of direct access to the blood reaching the plasma. So what is the longer, yung pinaka longer time wherein it will take the effect of the drug? Oral drugs or oral route, because it will pass through from the video that I have presented, GUT, liver, first pass effect, vein, heart, which is on the right side, then the lungs, then the left side of the heart, then goes to the artery. So that is a longer period of its effect compared to intravenous and intraosseous. Intraosseous rather. Next, how about patient's age and physical condition? For example, patient's age, pediatric clients may have intact and active metabolism. So it means that the drug will take its effect to what is expected. Adult, on the adult age, drug may take place. Okay, drug may take place and its process because metabolic response is still intact. And here comes the aged population. Those who are in the old age already, wherein we expect that the metabolism is delayed. So will that mean, sir, that absorption is delayed and slower to aging population compared to adult and pediatric? The answer is yes. Because this may depend on the response of the cell on how it will undergo with the effect of the drug. if the patient's age as deleterious, usually po class, if there are emergency situations that may happen to aging population, to the older population, usually yan is through intravenous already or through inhalation. Because if it is oral, then it may have longer time or pace pa of effect, mas longer compared to the adult and the pediatric population. Physical condition. Do you think an undernourished child or undernourished individual or an obese individual may alter absorption? Yes. For obese, ibig sabihin more than it exceed the ideal body weight. Class, remember, for obesity and for obese individuals, metabolic response is slow. The more na slow ang metabolic response, the delay ang effect ng gamot. So, because of the adipose tissues and the metabolic response of obese, yes, it may delay the response of the drug. Another, how about for undernourished naman, which is opposite of the obese? Yes, the lacking of nutrients of cells may not respond effectively and efficiently because the cells are deprived from nutrients and may not act accordingly as expected with the drug effect. So those are conditions by which may affect the degree and rate of drug absorption. Next, letter C, lipid or water solubility of the drug. Question, sir. Di ba we have preparation of tablet, capsule, tapos the capsule, oil base, meron pa yan, oil base. Capsule, tablet, oil base. From this drugs that I have, type of preparations that I have mentioned, which of the three may have fast absorption? The water soluble, yung fat or lipid soluble, or tablet? Which
Soluble pa.
Yes. Kasi 'di ba from our idea na why it's soluble, because it can easily be break down yung drug. Unlike for the tablet po class, ang tablet po it will take time to break down before it will be synthesized kasi we need more hydrochloric acid to break down the tablet before it will be absorbed by the intestine and detoxified by the liver. Unlike for the water-soluble drugs, it can easily be break down. It may facilitate appropriate absorption. Next, potential interaction with other drugs or food. This is what I have mentioned in our previous discussion. Some of you, lalo na for pediatric clients, you will advise ganito. Para hindi mo malasahan, samahan mo ng gatas. Para hindi mo malasahan, samahan mo ng juice. Okay. This is the example that I gave to you before. If you're taking a drug which is, for example, vitamin C, then you will mix it with a beverage which eventually highly acidic. Example, concentrated orange juice. Do you think it will help in the absorption? Try to imagine acid to acid. So ibig sabihin there will be a premature breakdown already of the drug. So ibig sabihin once you mix it with the food or with other drugs, it may break down its chemical component prematurely, and supposedly the drug must reach the stomach, and the stomach is the one responsible that will break down the chemical properties. And here you come. You will break the tablet. Okay. Then afterwards, mix it with the juice. Oh, what happens? What happens? It will be soluble with the juice, but it will mix already, it will cause changes already with the chemical properties of the drug. So that's the point that we are talking about. There are also other drugs that may not be taken at the same time. So that's why if you will ask your parents, There are your parents may have 3 or 4 antihypertensive drugs, but it is not taken in one time. It is not taken all of these 4 antihypertensive drugs will be taken only in morning all at the time. No, because it may interact and counteract each other. That's why it must be given on separate time. Sometimes it is given once a day, but 1 in the morning, 1 in the afternoon, 1 before sleeping. Because drugs may have the potential interaction with each other that may affect the potency. So what is the potency that we're referring? That is referring to the effect of the drug. Okay? So next is, did this routes have been introduced to you in the fundamentals of nursing or not yet?
Yes po.
Ayan. So probably I may connect with you on this medication administration routes. Now, the medication administration routes could be enteral or could be parenteral. Okay? The enteral routes are referring to drugs that had been absorbed by the gastrointestinal tract. So obviously includes the mouth, includes the GI tract. So anything that goes to gastrointestinal tract is enteral routes. Now, if we are considering parenteral routes, absorbed outside gastrointestinal, so it means these are parenteral, intravenous, intramuscular, subcutaneous, so on the level of subcutaneous, otic administration, so ear, conjunctival is through the eyes, nasal is through the nasal or nose, inhalation is direct to the respiratory tract, and topical is via skin. So outside the gastrointestinal tract is parenteral routes. Enteral routes is absorbed through the GI tract. Now, let us now have a review of some concepts referring to enteral routes. So let's start with oral. If you will notice in my presentation, it has a blue close open parenthesis na term. This is just for a guide, for you to be guided to easily remember concepts about oral medications or administration routes rather. 2 CAS-GIP. So remember 2 CAS-GIP. Sir, what do you mean by that 2 CAS-GIP? So class, usually pag sinabi nating 2C, ibig sabihin common and convenient. Oral is common and convenient. A meaning, AS meaning absorption is low. GI, most of oral medication or oral routes may cause gastrointestinal, gastric irritation. P, usually typical route for pain medications. So tandaan lang po yung 2 CAS-GIP. Ibig sabihin 2C. So what do you mean by the 2C?
Common and convenient.
Very good. AS.
Absorption
Absorption is low.
Low. GI.
Gastric irritation.
Cause gastric irritation. And P, pain medication. So these are the I just make a mnemonic for you to just understand and for you to just remember 2 CAS-GIP. So common, convenient, absorption is low. It usually causes gastric irritation and usually for pain medications. So class, remember, since it goes through the oral and passes through the stomach, almost all of the oral medication causes gastric irritations. Almost all. So that's why instances like when you take medications via oral, it must be in full stomach because it may cause gastric irritation. One of the drugs that are basically proven that may cause gastric irritation are steroids. Yung lahat ng drugs na steroids, yung may mga zone sa uli, dexamethasone, prednisone, ano pa ba itong mga drugs na to? Lahat ng may zone sa huli. Dexamethasone, prednisone, zone. These are steroids that eventually may cause gastric irritation and may cause possible ulcer. So that's why it must be in full stomach. Sir, why there are also medications that must be given on an empty stomach? Just to give you an example, anti-TB drugs, rifampicin. Rifampicin are given on an empty stomach because it may facilitate effective absorption. So yung may mga drugs tayo that are given on an empty stomach because it may facilitate what? It may facilitate effective absorption. However, may risk pa rin that may cause gastric irritation. So that's why most of the oral drugs or oral medication drugs may cause gastric irritations. So next is buccal. In buccal, remember C-group. Tandaan lang yung C-group, C-group. May H sa huli. C-group. May H. What do you mean by C-group? Buccal, usually cheeks and gums. Between cheeks and gums. Cheeks and gums. So that's why it's GU. Sir, ano yung pH? pH requires certain pH level for optimal strength. Usually, the buccal area, the drug are given on the side of the cheeks, between gums and the cheeks. However, di ba meron tayong saliva that is being secreted? It will be more effective. It will be more effective yung absorption kung mataas ang pH ng saliva. So that's why meron din certain limitation that it may require certain pH level to have optimum strength of the drug. So yun po yung tatandaan natin, C-group, CG or C-group. Ibig sabihin between the cheeks and the gums, C-group pH, it may require certain level of pH for optimal strength. So most of the drug, I missed pala to mention pala that in the oral drugs, the drug preparation that we say are most of the drugs, tablets, capsule, pills, powders, or liquids are for the oral. While for the buccal, the most common example of drug that are being given to via buccal is fentanyl. Fentanyl is a pain reliever. Usually, this is intended for cancer pain. Those who may have cancer, fentanyl is the drug of choice for pain management, but most fentanyl are given via buccal rather than oral because of its fast and immediate effect. So fentanyl, this is a pain reliever and usually intended for cancer pain. So next, how about sublingual? So remember, okay, let us have a review. Oral, let us remember the two CASGIP. So we have two C's, convenient,
Common and
and common and convenient. AS,
Absorption
is low.
very good. Next,
Gastric irritation.
PI, gastric irritation, and P,
Pain
Medication.
okay. Let us now proceed with buccal. What is our mnemonic for buccal?
Cheeks and gums.
PH.
Okay, C-group. Okay, so C and G, what does it mean?
Between cheeks and gums.
Very good. Then it will require
Certain level
of
of
pH.
level.
Okay, that's good. Now, let us now proceed with sublingual. All you have to do to remember sublingual is TARBs. Okay, TARBs. This is just a mnemonic. What do you mean by TARBs? Usually under the tongue. T. AR, opposite siya ng oral. Kasi in the oral, we mentioned it absorbs slowly. Unlike for sublingual, AR absorb rapidly. BS. Ano yung BS? It's absorbed rapidly, bloodstream. So bloodstream. Ibig sabihin, direct to bloodstream. So TARBs. Tongue, absorb rapidly, bloodstream. One of the common drugs that are given, one of the example of common drugs that are given sublingual is nitroglycerin. This is a drug that is intended for chest pain. This is anti-anginal. So what I have mentioned about angina, it's chest pain. Okay? So angina is termed as chest pain. That's why it is anti-anginal. So nitroglycerins are for chest pain and usually for emergency cases. Remember class if you will observe for emergency cases ng nagche-chest pain, most of the drugs are given sublingual. Okay? Lalo na, there are some also situations like if increase in the blood pressure, there are some drugs, most of the drugs are given also sublingual so that to support immediate dropping and sustaining of the blood pressure. So one of the example is nitroglycerin. So this is the next slide before I may have the break. So rectal. So in rectal, you will just remember RAIT. RAIT. Sir, what do you mean by RAIT? R, obviously rectum. Tapos AIT, absorb intestinal tract. Absorb intestinal tract. RAIT. So the common drugs that we may have is Dulcolax. O familiar tayo sa Dulcolax. Bisacodyl or Dulcolax. This is a rectal laxative suppository. A rectal laxative suppository that is intended for constipation. What is that? The dog. Or later on you will recite. Okay? So for the meantime, I just missed the presentation. Okay. Now, so when it comes to this, let's have first review the first 4 of the enteral routes. We have oral, we have buccal, we have sublingual, and we have rectal. I will not go back to the slide. Let us just remember the mnemonics that I have mentioned to you and the examples. For oral, we have the 2 Cas-Gift, common, convenient, absorb slowly, GI irritation for pain. So most of the preparations are tablets, capsules, powder, syrup. Buccal. For buccal, our mnemonic is SIGUP. It's between the cheeks, the gums, and may need certain level of pH. Concentration. Sublingual. Sublingual, remember, TARBs. Tongue, absorb rapidly, BS, direct bloodstream. And the rectal, we have RAIT. We have rectum, absorb in the intestinal tract. So before we proceed with the parenteral routes, so I may give first 5-minute break for you to have your health break and have your hydration before we continue and finish about parenteral routes. Thank you very much. Have your break first. Salamat. Okay, class, let us continue. So we still have 10 minutes before 7 o'clock. So to continue with our discussion on absorption, so we ended up with the discussion or review of the enteral routes. So we have parenteral routes. We have this absorbed outside the gastrointestinal tract. So all you have to remember in the intravenous is DABs. So what do you mean by DABs? DABs meaning directly or direct access to bloodstream. So intravenous is direct access to bloodstream. And commonly used drugs for intravenous, like if you are aware of intravenous fluids, normal saline, lactated dringers, these are example of common drugs given intravenous. So that's why if intravenous therapy will be introduced to you and discussed to you, most of the intravenous drugs are given direct to the bloodstream. So in short, in colloquial, the suero that you are observing in the hospitals are being given or directly through the bloodstream. So that is DABs. Next is we have, other than intravenous, we have intramuscular. For intramuscular, we have, remember, MLHSB3. MLHSB3. So DABs, MLHSB3. For MLHSB3, what does it mean? You will just remember that M is for muscle, LH less hazardous. We have the SB. It means stays in the blood longer. So it stays in the blood, and 3 up to 3 ml. Okay, what does it mean? Why up to 3 ml? Class, remember, when you will do intramuscular injection, the maximum amount or volume that is tolerable for intramuscular is only 3 ml. Don't go beyond 3 ml. If it is 5 ml already, 4 ml already, then please be careful in administering the drug, because if it is more than 3 ml, it may cause irritation of the muscle, or possibly this irritation of the muscle may lead to inflammation and soon may cause the muscular damage. So that's why it's only up to 3 ml. So ml, HS, B3. So ml meaning muscle, LH, less hazardous, SB, stays in the blood, and up to 3 ml. Intramuscular may not be recommended for ventrogluteal and dorsogluteal. So what do you mean by that? It's part of the muscle. If you will recall in the anatomy and physiology, the parts of the ventrogluteal and the dorsogluteal. Class, why? Because these are the instances or situations na may greater chances of nerve damage. Class, pag nag-cause ng nerve damage, this may cause paralysis. So always remember, don't give intramuscular via ventrogluteal or dorsogluteal, not recommended, because chances that may hit nerves and leads to paralysis. So let's have an example of intramuscular drug. An example of intramuscular drug is haloperidol. Haloperidol is an antipsychotic drug. Okay, so this is a drug that is given for problems with mental adaptation or illnesses. So haloperidol. So this may not exceed 3 ml. So haloperidol will be given intramuscularly. And how many degrees will you administer the drug via intramuscular? It's 90 degrees. Next, let us now proceed with subcutaneous. So intravenous, DABs. So what do you mean by DABs? We have direct absorb bloodstream, DABs, intravenous. So again, for intramuscular, ML, HS, B3. So M, Muscle,
Less hazardous
less
in the
hazardous
blood
in
up
the
to
blood.
3 ml.
Okay, good. So if in subcutaneous, you will just remember FTSM2. FTSM2. So what do you mean by FTSM2? Subcutaneous is through fatty tissues, SM between skin and muscle. Okay, the location is between the skin and the muscle. That's why, class, for subcutaneous administration, you will only give it via 45 degrees. Pag intramuscular, it's via 90 degrees. Pagka subcutaneous, it's 45 degrees. So 45 degrees administration so that only to reach between the skin and the muscle, which is subcutaneous. Class, the amount that can only be tolerated, or the volume that can only be tolerated by the subcutaneous is from 0.5 ml up to 2 ml. So unlike with the intramuscular, 3 ml, but unlike for subcutaneous, minimum of 0.5, maximum of 2 ml. Class, don't exceed 2 ml via subcutaneous because it may possibly damage the subcutaneous tissues. Another is, it may lead to gradual absorption. So what do you mean by gradual absorption? The gradual absorption is slow, step-by-step absorption. So matagal yung effect. Pag sinabi natin gradual absorption, long-term effect. So that's why example, a typical example of those drugs given subcutaneous are insulin. So familiar with insulin? Those that are given for uncontrolled diabetes. So that's why binibigay siya with subcutaneous so that the absorption will be gradual. Kasi pag binigay mo yan ng intramuscular, mabilis yung pwedeng maging absorption, and possibly because it may have an immediate drop of the blood sugar. So unlike with the insulin be given subcutaneous, gradual absorption, it stabilizes the blood sugar, and at the same time, it stabilizes on a long-term period. So subcutaneous administration. So insulin, sa problem with blood sugar, heparin. Heparin, those drugs, all those drugs ending in rin. Heparin, aspirin, lahat ng rin. Anticoagulant. So these are the drugs that may prevent blood clot. Kaya minsan if you will notice, also sa mga parents ninyo are taking Aspilet or aspirin, yan, those are the drugs to prevent blood clot that will cause obstruction of the blood vessel. So this is on the subcutaneous tissue. So this may not be anymore. So yeah, this is the last slide that we will have for this discussion. If you will notice, we have discussed concentration, peak concentration or maximum concentration and maximum time. If you will notice with this table that is presented to you, the effect of the drug is faster. That is aligned with the time. If it is given intravenous and intraosseous, the effect is 30 to 60 seconds. So meaning in 1 minute, the drug will take its effect. So if it is during emergency, intravenous is the best. So intravenous and intraosseous. Intraosseous meaning it's direct to the bone. The next is 2 to 3 minutes for endotracheal and inhalation. What do you mean by endotracheal? Have you seen patients in the ICU where tube is connected via mouth and that is extended up to the trachea? So there are drugs that are given via endotracheal, usually anesthesia. Anesthesia may be given endotracheal. Inhalation, anesthesia can be given also inhalation via the mask. Okay? So that will affect 2 to 3 minutes. Sublingual. Sublingual may have an effect 3 to 5 minutes. Intramuscular, 10 to 20 minutes. Subcutaneous, 15 to 30 minutes. Rectal, 5 to 30 minutes. Ingestion. Ingestion meaning oral, 30 to 90 minutes. Can you imagine the effect of the oral drugs will take 30 to 90 minutes? So almost 1.5 hours. 1.5 hours for oral drugs. So sa kanya talaga, in the oral drugs, the oral route talaga ang pinakamatagal. So that's why compared to intravenous, which is just only for 1 minute, compared to 1 hour and 30 minutes. For transdermal, which is topical, it may vary. It may vary depending on the properties and chemical properties of the drug. It may vary either minutes to hours, depending on the preparation of the drug. So class, this is a basic information that you will definitely have a mastery when it comes to time. Because when you will be assigned in emergency situations, always take into consideration intravenous intraosseous is the best route of administration for emergency situation. If there is no established intravenous site, what could be the next? It could be inhalation if it is not endotracheal. If it is not inhalation, the next is sublingual. So it's on a process wherein the option of route of administration will give you the idea depending on the condition if it is emergency. That's why if you will notice, dun sa mga period, if the period that it will stabilize the blood pressure for the whole 24 hours, that's why it's oral. Kasi it will need a longer time of its effect. That's why for oral antihypertensive drugs, it is given obviously via oral. So I think I will end up to this discussion. Are there any question? Are there any question from the group? Are there any question from the group? I will stop the recording.